We move on to the next presentation by Dr. Mariya, Doctor, Microbial Keratitis in Ichthyosis, Diagnosis, Challenges and Management. Dr. Mariya, please.
Thank you, sir. Thank you for giving me this opportunity to present today. So I'll be presenting a case of microbial keratitis in ichthyosis, diagnostic challenges and management. Main objective of this presentation would be to know about the various associated ocular manifestations in patients with ichthyosis, to explain the factors predisposing these patients to microbial keratitis, and to devise a comprehensive management plan for ocular manifestations in these patients. So ichthyosis is actually an inherited group of disorder affecting most of the integument. It is characterized by skin thickening, xerosis, that is dryness, and scale formation. It occurs due to defect in cell adhesion and desquamation, which leads to stratum corneum disruption and transepithelial water loss. Ocular affection involves mainly the eyelid, the meibomian gland, conjunctiva and the cornea mainly. So coming to our case, this is a patient, 30-year-old male, having short stature. On external examination showed generalized coats, large brownish dark scaling all over the body, eclabium, which is outward protrusion of the lids, along with digital constriction and palmar keratoderma. He presented with complaints of decreased vision in the left eye since the past few days. In the right eye, he had visual loss since the past few years post an episode of microbial keratitis. His visual acuity in the right eye was PLPR accurate, while that in the left eye was counting fingers. On examination, as we can see, he had total ectropion, atrophic meibomian glands. On the right eye, we see the cornea. There is a central leukomatous corneal opacity with an underlying adherent leukoma formation, while in the left eye, there was thickened congested conjunctiva and the cornea showed a corneal infiltrate. Since this patient was now difficult to examine on the slit lamp to know the exact size and dimensions of the infiltrate, neither was it possible for us to take a scraping. It was planned to do it in the OR. In the operation setting, we noticed that the patient had a geographic ulcer and even the lesion appeared to have dendritic edges. Hence, we went ahead and did the corneal scraping for gram and KOH, and also a RT-PCR for HSV was done. So, as of now, we had a provisional diagnosis of HSV stromal keratitis with ulceration, and the patient was started on topical Asevir eye ointment along with an antibiotic and lubricants. However, within next 3 days, the patient worsened, and by this time, we had the IFA PCR report, which came out to be HSV positive. So we now started the patient on tablet Asevir along with CMC, and within a week's time we could see that the ulcer edges had showed consolidation and also vascularization had started, and this is when we added steroids. This patient gradually improved. However, the course was extremely prolonged and it took around 3 months for complete visual recovery. So the various ocular tissue involvement, as already mentioned, include eyelids, meibomian glands, cornea, and infrequently the lens and the retina. And mainly it involves the eyelid and the meibomian glands because of the dryness of the skin and also the atrophic of the meibomian gland and cicatrizing entropion. Why are these patients prone to develop microbial keratitis? Because of the exposure keratopathy, unhealthy and malposition of the adnexa, irritation by scales of the keratinized lid, the meibomian gland dysfunction, epitheliopathy, and also vascularizing keratitis. The difficulties in these patients that we note is again applying lid speculum due to extreme lid eversion, risk of contamination while taking a sample, and evaporative dry eyes. And some patients also have limbal stem cell deficiency. Further, visual rehabilitation is extremely difficult in these patients because you cannot perform a graft because of the adnexal abnormalities. These patients required a combined approach in the form of ophthalmic management, dermatological management, systemic as well as psychological support. And most common prevention is useful in these patients. Hence, if lag ophthalmosis is absent, close follow-up and lubricant should be prescribed. And when present, eyelid management should be performed. And before visual rehabilitation, the adnexal pathology management is utmost important. So take home, ichthyosis requires an interdisciplinary approach. It affects the lashes, lids and the cornea. And these patients have exposure keratopathy, meibomian gland dysfunction and the abnormal adnexa, which lead to recurrent corneal epithelial defect along with secondary infection. Thank you.
Thank you, Dr. Mariya. Excellent presentation and very difficult case because we know that all these patients who have systemic problems in form of ichthyosis or atopic dermatitis, they all create a lot of issues, and all the issues you have highlighted. I would like to ask one thing, the corneal sensation was absent or present in this patient?
It was very difficult to assess because of the total ectropion, but in the right eye it was absent.
And because when he presented, he had difficulty in closure of the eyelids basically, and exposure was one risk factor.
Yes, sir.
So did we do anything for that?
No, our main focus was the healing of the ulcer. The oculoplastic surgeon did see it. We had started him on vitamin A, and they were later planning lid patch to put a patch graft for the lid.
Did they advise some surgical intervention for the lids or?
Now the patient is with them for follow-up. This was a very recent case, so the ulcer recently just healed.
Okay, thank you very much for excellent presentation.